Welcome to BreakThrough. Today we're going to be talking about the superior capsular reconstruction for the irreparable rotator cuff tear. We have with us in the studio Dr. Stephen Burkhart from San Antonio, Texas, Dr. Matthew Ravenscroft from Manchester, England, and Dr. Peter Millett from Vail, Colorado. Gentlemen, thank you for joining us.
Thank you.
So let's start with one of the most basic questions for those surgeons who aren't familiar with the superior capsular reconstruction, or SCR, because you gentlemen, between the three of you, have done over 250 SCRs over the last 4 years. What is it? Who first described it, and why? Maybe we'll start with you, Steve.
Yeah, well, Dr. Tiro Mahata from Japan initially described this, and it was just a reconstruction of the superior capsule where he fixed, in his case, autograft to the glenoid and to the humerus to basically replicate the function and the anatomy of the superior capsule. His first biomechanical study was in 2012, and then he had his clinical study in 2013. And Dr. Tai Lee was involved in that biomechanical study as well.
So Tai Lee and Tiro Mahata published their articles in 2012 and 2013. How many people across the United States at that time were doing the SCR?
I think really nobody was doing them in the U.S. at that time. And, you know, the things that happened, I think that the thing that was more appealing to American surgeons was that we wanted to have an allograft solution rather than the autograft with decreased morbidity. So the dermal allograft became a viable option. And then also the educational process to teach surgeons how to do it around the country.
Those are very good points, Steve. Now, Matt, I'd love to know your perspective. Was there a similar adoption in Europe?
Similar, but a little bit slower, a little bit behind, because we sort of were looking at the topic, but we weren't too keen on using the fascia lata because of the donor site mobility and the time taken to harvest it and prepare it. So when the dermal allograft came on, that sort of sparked some enthusiasm, and then obviously we were just waiting to get some results, some papers, see what the takeoff was going to be, not just across Europe, but it's going sort of worldwide, the takeoff now. And at most courses that we now teach on, it is the hot topic of discussion at most of the courses.
So it was something that gained a lot of acceptance all around the world. Now, Peter, you lecture all over the world talking about complex shoulder issues. What's your explanation? Why do you think it gained such acceptance around the world?
Well, I think the SCR really filled a void. We had reverse shoulder arthroplasty, not an ideal option in the middle-aged active patient that needs some type of procedure for a massive cuff tear. And then we had tendon transfers for which the results, it's maximally invasive, and the results are not always as good as we'd expect. So we have a minimally invasive option, and I think it really filled that void quite nicely.
Now, Steve, we've learned a lot over the past 4 years. In fact, you were part of the BRASS group study that was published in the Journal of Arthroscopy in January. Maybe you could briefly mention some of the lessons learned.
Well, I think the biggest lesson we learned was what the proper indications are. So what we concluded finally as a result of that study is that it should be a patient that has an irreparable cuff tear involving the supraspinatus and or infraspinatus. They should have no glenohumeral arthritis. They need to have an intact deltoid and trapezius, and either an intact or a repairable subscapularis. The other thing we learned is that you really should use the thicker grafts. We had failure with the 1 millimeter thin grafts, so now we routinely use the 3 millimeter dermal allografts.
Now, there's a lot of debate right now about repairability of tissues versus restoration of function. Matt, what do you tell your patients? Are you doing this procedure to relieve pain or to restore or improve function?
For me, it's mainly a pain-relieving procedure, because the vast majority of our patients are in that sort of 60-year-old age group, and for my indication, it's a irreparable cuff tear, but in that compensated shoulder where they have got flexion. So in those patients, it's a great option for pain relief. But also in that younger patient who's pseudo-paralyzed, it's an option we're talking about as well. Rather than going straight to reverse, it is an option for those patients.
So Peter, have you had a similar experience?
I've been really surprised at the functional gains that my patients have achieved with this. I thought it was going to be a pain-relieving option, but I've had patients that have been pseudo-paralytic and have regained overhead activity. Other patients that their strength has gotten back almost to normal. So I've been impressed with the functional gains as well.
So thank you, Peter, for bringing up that hot topic of pseudoparalysis. Now, guys, what if you saw a patient in your clinic that could not actively elevate their arm above their shoulder? Should the SCR be considered in this patient?
Absolutely. Yeah. You know, there is this school of thought right now that says that the only way you can reverse pseudoparalysis, true pseudoparalysis, profound pseudoparalysis, is with a reverse total shoulder replacement, because it provides a fixed fulcrum so that you can use your extrinsic muscles to raise the arm. We have just had a paper accepted for the Arthroscopy Journal. We had a series of 10 patients with what we call profound pseudoparalysis, that is less than 45 degrees of active elevation. In fact, ours, of those 10 patients, they had a 27-degree average active elevation. And 9 of the 10 reversed the pseudoparalysis, and they had an average of 159 degrees post-op.
So pseudoparalysis is not even in your algorithm to decide preoperatively if somebody's a candidate for an SCR?
No, not at all. In fact, as I said, we can reverse that, I think, not in every case, but in a significant number of cases, if you have the proper indications. And I think, I've heard you talk about your traffic light analogy on who the proper patient would be, and you may want to just go through that with us, but I think that's a great analogy.
Yeah, so basically, guys, it's a green light, yellow light, and red light. A green light is your perfect patient, the ideal candidate for the SCR. I think of my perfect SCR patient, I'm thinking of somebody who's healthy, 60 years old, somebody has an isolated supraspinatus tear, and then somebody with no or minimal glenohumeral arthritis. Now, on the other end of the spectrum, that red light would be an unhealthy 90-year-old patient who has an irreparable subscap in advanced severe arthritis, and that person obviously wouldn't be a great candidate for the procedure. And then obviously your yellow light, maybe not the perfect indications, but still a candidate for the procedure. So let's switch gears a little bit and talk about the technique. What do you guys do with the biceps tendon and the superior labrum?
Personally, I always do a biceps tenodesis. If it's an older patient, I'll do a tenotomy. The superior labrum, if it's healthy quality tissue, I'll preserve it, but I'll prepare the bone medial to it so I can get healing of the graft. If the labrum is deficient or very degenerative, then I'll do a labrectomy.
Yeah, I mean, pretty similarly. In most of my patients, they're more in that sort of 60s age group, so I don't mind doing a tenotomy, but I do remove that superior labrum because me, I want the biggest area of bone sort of fixation for my graft medially.
Steve?
Well, I'll do a tenodesis in most patients, but I'll debulk the superior labrum to try to provide a little more footprint for contact with my graft, not necessarily a full labrectomy.
Okay, so what about your repair technique? Now, Peter, you were the lead author on 2 studies that looked at the safety and biomechanics of glenoid fixation for the SCR. Maybe you could briefly discuss what we learned from those 2 articles.
Yeah, that's a great point. The 2 articles, the first one was on the anatomy and where you can actually place the anchors, and we found that you could safely place 3 anchors on the glenoid. The most important anchor is probably the 12 o'clock anchor. You have to be a little bit careful with the trajectory so that it doesn't perforate through the glenoid. And then the other 2 anchors can go at 10 and 2 o'clock, and that way you have more points of fixation. The second study looked at the biomechanics, and it showed really that whatever type of anchor you use, if you use knotless, knotted, that we had very consistent strength of fixation so that you could achieve a really strong construct, because it needs to be strong at time 0.
Thank you, Peter. Maybe, Steve, you could briefly discuss the fixation on the greater tuberosity side. Has it changed at all in the last 4 years?
Yeah, it has. In our original study with the brass group, we had a higher failure rate than I would have anticipated or wanted, and I think we didn't have our anchors close enough and secure enough on the humeral side for the size graft. And I think the way you need to look at it is it's like a rotator cuff tear. If you have a tear in the cuff that's big enough, you would use 3 humeral anchors on the medial row. You need to do that with your graft. So typically, if I have an AP dimension of my graft that's more than about 25 millimeters, I'll use 3 anchors, which ends up being probably most of these grafts.
And I've heard you talk about the double pulley technique. Would you also use that too?
Yes, and that's the other thing. You want to be sure to enhance your healing as much as possible, so we get a double mattress with a double pulley technique using the safety stitches from the swivel locks. But also that sets your tension. Right? That is critically important. So by bringing that double pulley down, it brings that graft directly over your anchors and sets that tension that you've templated out by the size of your graft.
So I guess that leaves side-to-side sutures. Matt, what are your thoughts about side-to-side sutures?
I think they're equally as important. We know from cadaveric studies that the sutures from the infraspinatus to the graft do restrict superior migration. They also help retract the cuff and improve your view. So once you pass your sutures to the infraspinatus at the back and subscapularis at the front, as you pull on those sutures, it basically brings the posterior cuff and the anterior cuff apart and gives you much better access and view for the graft to come into the joint.
The other thing that I do to help with visualization is I'll have a traction suture through the supraspinatus, and I'll bring that up through the navicular portal so it's pulling proximally, superiorly, getting that supraspinatus out of the way so you can see the glenoid better to prepare that.
So Steve, maybe we should talk about the graft and its preparation now. What do you use and why?
Well, I use the 3 millimeter Arthroflex dermal allograft, for a variety of reasons, but primarily because, you know, it has the strength you need. It's 3 millimeters, and biomechanical testing shows that that's very good, more than adequate. It also is prepared in such a way that they kill the cells, they eliminate 97% of the DNA so that there aren't any real immunogenic considerations here, rejection phenomena. And it also, the fact that it's a dermal allograft, it has the porosity for ingrowth of cells and vascular channels.
Have you guys noticed a similar experience, well tolerated with your patients?
Yeah, I like it because it's very biocompatible. I've never seen an adverse reaction to it, inflammatory response, and it's got great suture retention strength as well at time 0.
So you mentioned this, Steve. I thought it was kind of interesting. You said 3 millimeters. Does thickness matter?
Yeah, thickness is important. You know, it has to have the strength to withstand the loads that it's going to be facing. And the biomechanical testing shows that as you increase from 1 to 2 to 3 millimeters, that the ultimate load goes up exponentially.
So what about post-operatively? I've seen a few articles that compare the preoperative to the post-operative acromial-humeral distance. Post-operatively, how important do you think the acromial-humeral distance is, Peter?
The short answer is I don't think we know. I've had patients that have the humeral head still elevated that have good function. I've had patients that the acromial-humeral distance is normalized that have had good function. I think it's something we strive for. We want to see the humeral head recentered on the glenoid, and I think that's something that I look at more frequently. Look at the restoration of the Gothic arch of the shoulder.
I think the important thing is what Peter said, is the centering of the humeral head on the glenoid. And I think that the acromial-humeral distance is not a good indicator of that because it can vary several millimeters depending on whether the shoulder is centered on your plate, and it can vary according to whether the angle of your beam is 20 or 30 degrees off. So I think it's not a good measure.
And as I said in my indications earlier, this is a pain relieving procedure. You know, I think getting the pain right and getting the head centered, but the actual per se distance, I'm not too worried about.
So what about the arm position to determine the proper graft tension, Peter?
Yeah, I think graft tension is really an important factor. You want the graft to be tight when it's in there, otherwise it'll have too much laxity and it won't work like a ligament or like the superior capsule to restrict proximal migration of the humerus. So I think tension is important, and there's a variety of different ways you can achieve that. Arm position is important, particularly if you use a technique where you're putting all your sutures in on the outside and then shuttling the graft in. One thing that I do is I actually tension it once it's in situ. I fix it medially, and then I put a grasper on it to figure out where I'm going to perforate with my medial row of anchors, and then I can tension it in situ. So if I'm off a little bit, I can make it up by passing the sutures. Typically, I'll put the arm in about 20 to 30 degrees of abduction when I do the graft fixation.
Matt?
And I'm the same as Peter. I like to have the graft in and just feel that tension with the scorpion, just see what my tension for the fiber tapes is going to be.
And Steve?
I'm a little bit different because I place my sutures through the graft external to the body, not where it's outside of the joint. So what I do is place my anchors, I measure template between all of the anchors, and then I reproduce the measurements on the graft so that I can very precisely set the tension based on that. And I take those measurements with the arm in about 30 degrees of abduction.
I think we can all agree that the tensioning is the most important part of the operation.
Yeah, if you put it in loose, it won't have a biomechanical effect. So you want it to be tight when the arm is adducted.
So if you're going to err a little bit, you want to err on a little bit more on the tension side than under-tensioning it.
And I think the other thing about tension is it's not just medial lateral, it's also anteroposterior tension as well. So when you do those posterior sutures we mentioned and the anterior suture, as you tension from A to P, that also increases tension from medial to lateral as well.
No, I agree with you guys. I think that tensioning is so important that what we'll do is a timeout during the middle of the procedure, and we'll make sure, A, that the humeral head is centered on the glenoid, B, that we're in neutral rotation, and that C, that we're in the proper amount of shoulder abduction. Now, if we could just have just one pearl from each of you about your technique, what would you like to share with us, Steve?
Well, typically if I have a large graft, I'm going to split my cannula, the passport cannula, so along one side, so that I can then take it out from around the sutures, because I'm going to pass the sutures out externally, and that way I can just pass the graft through that percutaneous puncture and have more space. That avoids graft capture within the cannula.
Matt?
For me, it's meticulous suture management. I don't mind having more holes. I'd just rather have as many holes as I need to get the sutures in the correct place. So suture management for me.
Peter?
I think the versatility of the procedure, it's useful for isolated irreparable supraspinatus tears, combined super and infraspinatus tears, and we've used it now for some subscap tears as well, and we're kind of looking at our early results doing sort of an anterior capsular reconstruction. So the versatility of the procedure is really something that's useful for me.
Thanks, guys. So now on to the post-operative protocol. What are you guys doing with the SCR patients after the surgery?
Well, I think the general principle is you want to go slow with these people because you don't want to overcome the graft in any way. It's got to revascularize, and it's going to become weaker before it becomes stronger as it does revascularize. So what I do is I keep them in a sling for 6 weeks. At the end of 6 weeks, we start them on passive overhead motion. We delay strengthening typically until 4 months. And the literature would indicate that you're not getting adequate strength return to that graft until 3 to 4 months to allow them to start strengthening.
Now, do any of you guys have your post-operative protocol published?
Yeah, we recently published a protocol similar to what Steve outlined, so conservative, allowing for the graft to revascularize and repopulate with cells.
Now, we know that Teru Mahata's patients with fascia lata after an SCR did very well. Maybe one of you could describe the published clinical results of dermal allograft with the SCR.
I think Teru's results were really terrific, but he had sort of a selected group. He perfected the procedure and then published his results. There's 3 studies now which I'm aware of in the literature, one from the Brass group, which I think you and Steve were involved with, one from Hirahara and one from Pennington as well. And they've all demonstrated the early learning curve results, but the results overall have been pretty satisfactory. It was 75 to 90% good to excellent results. That's mirrored the experience we've had. We've had 90% good and excellent results in our patients as well.
Thank you. And we're also following several hundred patients with the SOS database after the SCR as well.
It'll be really interesting to see what comes of that.
Yeah, they're doing very well. So now on to the topic of suture augmentation. Are any of you guys augmenting your dermal allografts with suture?
It's something I've been doing for a while now, based on my early experience with my patients. So I had a few failures initially when they failed off the glenoid side. So then I thought, how can I protect that graft before it incorporates? As we know, it gets a little bit weak before it gets strong. So I use an internal brace. I have a swivel lock in at the 12 o'clock position, similar to Peter's anchor, and the 2 tails come out to my lateral row of my speed bridge. Tensioning it is important. We've talked a lot about tensioning of the graft. So you can tension the internal brace independently of the graft. So first of all, I tension my graft, as we've talked about. And what I'll do, I'll push up the humerus as far as I can to its maximum superior migration. I'll take the tension off a little bit and then tighten the internal brace at that point. So what I'm doing, I'm just protecting that last little bit of superior migration, just to protect the graft from its final sort of mechanical load. And that way I'm sharing the load, so it's an internal brace on top of my SCR, which in itself is a form of internal brace.
Oh, that's great. I'll do something a little bit different. I'll do a purse string around the graft outside the body. I'll just take the scorpion, go up and down, go all the way around, pull on it, pull on this, make sure that I've tensioned the purse string properly. And that way it acts like a ripstop all the way around 4 edges, and then also kicks in like an internal brace, like you said, when you're properly tensioning it. So it's a seatbelt at the extreme of motions, because we know that just like we found from the canine study from the Mayo Clinic with Julie Adams and Scott Steinman, these grafts get weaker before they get stronger. So some way to augment it and help protect it during that healing phase.
Initially, your purse string, as well as giving you some internal brace from medial to lateral, is also giving you that ripstop stitch from your posterior graft cuff to your anterior cuff, isn't it?
Agree. Yeah, absolutely. So gentlemen, what if a patient fails? Let's say they were doing well, and then at 3 months, they fall onto their shoulder. Is it reasonable to redo the operation?
I think fortunately that's a rare situation. I had a patient last week that fell. We got a follow-up MRI, the graft's intact. So in most cases, the graft's going to be strong enough that it's going to withstand those. I have had the instance where I had a patient who was doing well at a year out and lost his function after a trauma, and he tore the graft medially. And we were able to actually go in and repair it back to the glenoid, and he regained his function and was doing well. So I think it is possible to revise them.
I had a similar case about 2 weeks ago, and this was a 72-year-old lady that was 2.5 years post-op superior capsular reconstruction. She had an excellent result, and she had a very traumatic event, a fall down a stairwell. And she had an interesting tear because she had a stump of her graft left on the greater tuberosity, but a transverse tear across the graft with the rest of the graft still attached on the glenoid. And I was prepared to go in and change out the graft, when we operated, but actually found that it was repairable, and both sides would come over to the bone bed, and I could do a load-sharing ripstop with margin convergence to bone. The interesting thing about her graft was that it had clear vascular markings on both sides. And so I feel like by just repairing the graft, I saved that 4 months of revascularization by just repairing her own graft.
So you repaired it just like a rotator cuff repair?
Exactly like a rotator cuff repair.
Great segue. So speaking of the rotator cuff, have any of you guys fixed the rotator cuff over your superior capsular reconstruction?
Yes, I've had a number of those, and it's sort of a sandwich repair, and it makes a really nice MRI afterwards if you're able to get a complete repair over the top. And I've had some excellent examples that we have some videos of people that have both profound pseudoparalysis and external rotation lags that have reversed fairly rapidly after the repair plus the SCR graft.
And it makes sense. Anatomically, you have the superior capsular reconstruction, and then anatomically, then you have the rotator cuff on top. So do you guys agree then, in certain circumstances, when you can repair the cuff over the capsule, you will? Peter, Matt?
Yeah, it may help with increasing the biology too, bringing more vascularity to the tissues.
Yeah, no, I agree. I think it's a very important part. And you've got those extra sutures from all parts of your medial row, lateral that you can use to bring the cuff over.
So gentlemen, as we conclude this breakthrough episode, any final thoughts on the SCR? We'll start with you, Peter.
I think this really fills a niche in my practice for the young patients with massive tears or the active older patient that doesn't want to have an arthroplasty. It doesn't burn any bridges. It's joint preserving, and it's really been a game changer for me.
Similar, and our numbers of massive cuff tears in the elderly are going down, because that's a painful procedure, long time to rehab. We find the SCRs are just doing better. They're less painful, and their outcomes are frankly better with lower retear rates.
Steve?
Yeah, to me it's a game changer. I think that you have a joint preserving operation, minimal complications, and I think it is a fantastic addition to our armamentarium, but you have to remember that it's not really an easy, quick procedure. These don't take 30 to 45 minutes to do. They take upwards of 2 hours in most cases. So once you go through that learning curve and you learn how to do it, it's a very gratifying operation for you and for your patients.
So gentlemen, thank you once again for joining us today. You guys were absolutely fantastic.
Thanks.
Thank you.
For more information on the superior capsular reconstruction or hands-on educational event, please contact your local Arthrex representative. You can also visit and register at arthrex.com to learn more about how the SCR can be used to help you treat your patients better.